The People's Pharmacy podcast is supported in part by CocoVia. CocoVia cocoflavanols support both cardiovascular health and cognitive function by promoting healthy blood flow, transporting oxygen and nutrients to vital organs and muscles, including your heart and brain.
CocoVia now comes in an even more concentrated formula, with 450 milligrams of cocoflavanols, 5 times more than the leading dark chocolate bar and 15 times more than the leading cocoa powder.
CocoVia has a proprietary process that preserves cocoflavanols at the highest levels, and the product undergoes rigorous testing at every stage, which allows them to guarantee the highest level of cocoflavanols per serving and to provide the purest, highest quality product possible.
People's Pharmacy listeners can now try CocoVia for 25% off by using the code Peoples25 at cocavia.com. That's COCOAVIA.com. When you think of COVID-19, do you imagine breathing problems or a ventilator? What about your cardiovascular system? This is the People's Pharmacy with Terry and Joe Graydon.
COVID-19 affects almost every system in the body. How is this disease affecting the heart? What about the side effects of medications used in its treatment?
The remdesivir trial was halted prematurely because it revealed a small benefit against COVID-19. Was that a mistake?
Dr. Steve Nissen is a leading cardiologist at the Cleveland Clinic. He'll tell us why a stent is important during a heart attack, but may not really help at other times.
Coming up on the People's Pharmacy, COVID-19 and your heart.
In the People's Pharmacy Health Headlines, around the world, people who have recovered from COVID-19 are being retested. Some of them are testing positive again. Does that mean they've become reinfected? These observations, both from the Korean CDC and from sailors on the USS Theodore Roosevelt, would be alarming if they mean people can catch the disease repeatedly. The US CDC commented that the positive tests from the recovered sailors might simply indicate that it takes time to clear away all the viral debris from the body. This possibility seems even more likely based on the report from the Korean CDC. It recently published results from an investigation of 285 cases of people who tested positive after recovery. The agency initially treated all such cases the same way they treated initial positive tests, with isolation and contact tracing. Only 3 of the 790 contacts who were identified actually developed the disease. Those 3 individuals had contact with other infected people through their church or household. Investigators attempted to culture the virus from 108 of the people who had retested positive. None of those attempts were successful. As a result of this research, South Korea no longer requires patients who retest positive to be isolated.
Sweden's model for managing the coronavirus pandemic is generating tremendous controversy in Europe and around the world. The country never instituted a widespread lockdown. Cafes, restaurants, and businesses have remained open, and youngsters have continued to attend classes. Although the country's public health authorities have denied that they're seeking to achieve herd immunity, the so-called soft Swedish approach encourages people to work from home, but is not mandatory. Over the last week, Sweden reported the most deaths per capita compared to other European countries. For example, Sweden had a death rate of 371 per million residents. That's 8 times the death rate of Finland or Norway. Only time will tell if the Swedish model was a better approach than the more rigorous lockdown instituted in other Scandinavian countries.
If you've been wondering whether wearing a face mask is worth the hassle, hamsters in Hong Kong have news for you. Put that mask on for your neighbor's sake. The researchers didn't put tiny masks on the rodents. Instead, they deliberately infected some of them with the SARS-CoV-2 coronavirus and housed others near them. Without any barrier, 67% of the healthy hamsters contracted the infection. When the scientists covered the healthy hamster's cage with surgical masks, the infection rate dropped to just 33%. Even more impressive, covering the cage of the infected hamsters instead reduced spread of the virus to just 17%. In addition, the hamsters who did become infected in that situation had lower viral loads. One of the researchers noted that the hamster experiment shows clearly that if you wear a mask, you are protecting other people.
A diet rich in colorful vegetables, berries, and fruit appears to reduce the risk of developing Alzheimer's disease and related dementia in later years. The Framingham Heart Study started in 1948. The offspring of those participants were recruited for their own epidemiological investigation. They answered questions about their diets every few years. They also relate health problems and diagnoses. The latest findings reveal that people who consume foods providing the most flavonoids were least likely to develop dementia. Those foods include tea, apples, pears, oranges, blueberries, strawberries, and red wine. The authors conclude that those with the highest flavonoid intake are about half as likely as those with the lowest intake to develop Alzheimer's disease. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. COVID-19 continues to dominate the health news. How is it affecting the practice of medicine at a major medical center like the Cleveland Clinic?
Specifically, how is it changing a specialty like cardiology? Are people staying away from the emergency room for fear of catching the virus?
To find out, we're talking today with Dr. Steve Nissen. He's Chief Academic Officer of the Seidel and Arnold Miller Family Heart Vascular and Thoracic Institute at the Cleveland Clinic. He holds the Lewis and Patricia Dickey Chair in Cardiovascular Medicine. He co-authored with Dr. Mark Gilinoff Heart 411, the only guide to heart health you'll ever need.
Welcome back to the People's Pharmacy, Dr. Steve Nissen.
It's a pleasure to join you again.
Dr. Nissen, what's it been like at the Cleveland Clinic? I mean, you folks are renowned for cardiovascular medicine. I suspect you have continued to see patients with heart attacks, with strokes, with other cardiovascular complications. How has COVID-19 affected you?
Well, it's affected us in every possible way. First of all, the entire hospital, of course, is focused on dealing with this pandemic. But with respect to heart disease, there's a phenomenon that's been going on that is very concerning to us. And that is that patients that have chest pain symptoms are frequently staying at home. They're not coming in until much later in the course of their illness, and they're really suffering the consequences. Fear of the COVID-19 virus keeps people from seeking medical attention. And when you're dealing with heart disease, that's a pretty dangerous situation to be in. So the census in our coronary intensive care unit is actually low compared with its historical norms.
That's scary, though, isn't it?
It really is. And we've been speaking out a lot about this publicly. We described, it was actually described in the New York Times, a patient who stayed home for a week after a heart attack. And what actually happened to him is he ended up having a rupture of the interventricular septum. That's the muscle between the right and the left ventricles of the heart. And he needed emergency surgery to save his life. He would have done very well, probably, if he could just come in right away with his heart attack.
So, Dr. Nissen, what recommendations do you have for people?
if you have chest pain, if you have shortness of breath, if you have heart-related symptoms, particularly if you know that you have heart disease, don't be afraid of the virus. We have put in place, and every hospital's done this, safeguards to keep patients that have symptoms that are likely to be coronavirus separate from patients that have, say, heart-related or other organ system symptoms, so that you shouldn't be afraid of contracting the virus by seeking emergency medical attention. So if you have chest pain, call 911, get to the hospital. We'll take good care of you. We will protect you against getting infected, and we'll make sure you get the right kind of care. And that's true wherever you live.
Dr. Nissen, we think of COVID-19 as primarily a lung disease, an infection that really hits the lungs hard. But does it also affect the vascular system?
It does indeed. And we're learning more, literally every week that goes by. There have been a number of patients. We know that about 20 or 25% of patients with COVID-19 have an enzyme leak that is cardiac enzyme. It's heart-related enzyme. It actually mimics the enzyme release we see with a heart attack. And so it can actually be confused with a heart attack. But it's actually due to the virus damaging the heart muscle. So we know that occurs. We have also seen that the COVID-19 infection promotes blood clotting. And so patients are coming in with strokes that appear unrelated to having the typical plaque buildup in arteries that we expect to be associated with stroke. It's probably related more to clotting. And we've seen clots everywhere in the legs and in other locations that can lead to a need even for amputations. And so some of the survivors of COVID-19 infection have actually had limb loss related to this clotting of blood vessels in the periphery. So this virus really does hit the lungs very hard, but it can also affect blood vessels, it can affect the heart, and it can affect many other organ systems, including, by the way, the kidneys, leading to kidney failure.
Dr. Nissen, we've heard that some patients who were either on anticoagulants or put on anticoagulants have better outcomes when they end up with the COVID-19 disease. Can you give us a little insight on what's happening there? And is this something that your colleagues should be considering?
Well, unfortunately, it is unproven. And one of the problems now that's going on is every conceivable therapy is getting studied, but not necessarily studied in a rigorous way. And the problem is a lot of it is very anecdotal. Yeah, we gave anticoagulants to a bunch of people and they seem to do better. And science and medicine just doesn't advance that way. The only way to answer those questions is to do what we call randomized controlled clinical trials, where half the people might get an anticoagulant, the other half might get a placebo, and then you look out and you see who does better. In the absence of those kinds of studies, it's pretty speculative whether it's a good idea to give anticoagulation or not. And please understand that these blood thinners have adverse effects. And we've seen over and over again in medicine that if we jump to conclusions, we tend to make mistakes. This is what happened with this terrible situation with hydroxychloroquine, where you had, politicians telling people that it was a great therapy when there weren't any good trials. And then when the trials were finally done, if anything, it actually increases mortality rather than decreasing it.
Well, speaking of hydroxychloroquine, we have had a lot of, shall I say, excitement on our website because we've written about two studies that were published in reputable journals, the New England Journal of Medicine and JAMA, in which both studies were, shall we say, disappointing when it comes to hydroxychloroquine in the case of the New England Journal of Medicine, and in the case of JAMA, hydroxychloroquine and azithromycin. And in both cases, there was no evidence of better outcomes. And yet there are literally dozens, hundreds, maybe thousands of people who are very much attached to these drugs and think that there's something wrong with the research and that the journals were really not being fair or objective about the drugs. Can you give us a quick insight about where you think we are with regard to those two drugs? And when we come back after the break, we'd like to ask you about the cardiovascular implications of those drugs.
Well, first of all, the whole concept of using hydroxychloroquine and azithromycin was never well-founded. It was based upon the kind of anecdotal evidence that I was just talking about a minute ago. A lot of us never thought that this made any sense. And the studies, of course, proved this. These are reputable journals. They have no hidden agenda. The advocacy of the drugs was not based in good science. And we had lots of reasons to believe that there might be downsides of both hydroxychloroquine and azithromycin. The only thing I can say to the public is, the people out there that have been hoarding the drug and have been taking it, sometimes even without a doctor's prescription. I don't know exactly how they get your hands on it. This is not good common sense, and people need to leave it behind. We need to move forward with proper studies of therapies that actually have a chance to work. Hydroxychloroquine and azithromycin, I think that the jury is now out that these therapies just don't work. And I trust the journals to publish the data correctly.
Now, of course, we still lack randomized, double-blind, placebo-controlled trials. And so we might learn that the drugs do prevent infection. We'll have to wait to see. But at the moment, those trials have not yet been published, have they?
Well, we haven't seen the definitive evidence. But, I never thought that the hypothesis made a lot of sense. And so from day one, I have been a skeptic, as have many people who do, as I do, clinical trials for a living. Always want to have an open mind. If somebody can show convincing evidence, fine. But we've been aware of the downsides with these drugs. And so you really want to have a very strong case for using a drug. All drugs have important risks. And to forge ahead taking drugs without good evidence, without fully understanding the risks and the benefits, is never good medicine. And in this case, really, we put the cart before the horse in those people that were advocating this therapy.
You're listening to Dr. Steve Nissen, Chief Academic Officer of the Seidel and Arnold Miller Family Heart, Vascular, and Thoracic Institute at the Cleveland Clinic. He holds the Lewis and Patricia Dickey Chair in Cardiovascular Medicine. Dr. Nissen has conducted countless clinical trials and has served on the FDA Cardiorenal Advisory Panel. Dr. Nissen co-authored with Dr. Mark Gilinoff Heart 411, the only guide to heart health you'll ever need.
We understand that many people might be reluctant to spend time in an emergency department under the current coronavirus circumstances. Nonetheless, we want to reinforce Dr. Nissen's message that symptoms such as chest pain or tightness, shortness of breath, pain that's spread to the jaw, back, or arms, sweating, or sudden dizziness deserve emergency attention.
After the break, we'll talk more about hydroxychloroquine and Z-Pak, also known as azithromycin.
What are the potential complications with heart QT interval? And what is it anyway?
Do other medicines have an impact on our risk for COVID-19?
It might be too early to tell what the long-term effects of COVID-19 could be. Stress is not good for the cardiovascular system, and nearly everyone has been under stress in the pandemic.
How has the pandemic affected cardiovascular research?
Speaking of research, we'll find out what Dr. Nissen thinks of ending the remdesivir trial early.
Are there any other drugs on the horizon?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
The People's Pharmacy podcast is sponsored in part by Kaya Biotics. KAYA Biotics offers the first probiotics which are both certified organic and hypoallergenic.
All probiotics are produced in Germany under laboratory conditions with high-quality ingredients and under strict regulatory oversight.
The 3 available formulas are created for very specific purposes, such as strengthening the immune system, fighting yeast infections, and helping with weight loss.
To learn more about Kaya Biotics probiotics and the important topic of gut health, you can visit their website, KayaBiotics.com. That's KAYA Biotics.com. Use the discount code PEOPLE for $10 off your first purchase. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon.
The People's Pharmacy is brought to you in part by Kaya Biotics. Probiotic products made in Germany from certified organic ingredients. KAYA-biotics.com.
And by CocoVia, the maker of high-potency cocoflavanol supplements that support cognitive and cardiovascular health. More information at cocovia.com.
Also by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
Today, we are talking about the coronavirus and how it affects the cardiovascular system. There's been a lot of controversy regarding hydroxychloroquine and azithromycin. How do these drugs affect the electrocardiogram?
Our guest is Dr. Steve Nissen, Chief Academic Officer of the Heart and Vascular Institute of the Cleveland Clinic.
Dr. Nissen, we were talking about hydroxychloroquine and a very commonly prescribed antibiotic, azithromycin, often prescribed under the brand name Z-Pak. And we were sort of alluding to cardiovascular potential problems. And by that, I mean something called the QT interval. Now, it turns out there are literally dozens, if not scores, of medications that can do that. Can you please tell us, kind of in layman's terms, what the heck is a QT interval? And if you prolong it with a medication, or in this case, 2 medications, what are the potential complications?
Well, it's something we measure on an electrocardiogram, and it relates to the repolarization of the heart. And that's a complicated term for the kind of electrical changes that occur during the cardiac cycle. The reason it's important is the number one cause for drugs to be removed from the market over the last 30 or 40 years in the United States is a prolongation of this QT interval, which leads to a vulnerability to have serious, even potentially lethal heart rhythm disturbances. Now, we've known for a long time that both hydroxychloroquine and azithromycin can prolong the QT interval. You never want to give multiple drugs that do this because you may have additive effects, which is one of the reasons why, frankly, I was very worried when I started to see this advocacy for giving hydroxychloroquine with azithromycin. And I have to tell you anecdotally, I was attending in the coronary care unit a couple of weeks ago, and sure enough, a patient came in who was taking hydroxychloroquine for another indication, and it's a useful drug for people that have certain disorders like rheumatoid arthritis. But this patient had a QT prolongation and had a nearly fatal heart rhythm disturbance. And so we have to take medications seriously. We have to understand their risks and benefits. The two of you have spent your careers talking about this issue of benefit versus risk with medications. And I agree with you that you have to understand these things in order to use medications wisely. This is an example where, based upon flimsy evidence of a benefit, we had drugs that have very well described risks being used, and in some cases, We understand we have people that had access to these drugs for other purposes that were then hoarding them. We even have stories out there of physicians prescribing these drugs for members of their family to prevent COVID-19 infection. And that's just not a wise thing to do. And so we need better trials, but we have to be respectful of the fact that these drugs, like all drugs, have risks as well as benefits.
Dr. Nissen, quite aside from hydroxychloroquine and azithromycin, which also can have a similar effect on heart rhythm, do the medications that people are taking for their blood pressure or their heart conditions have any impact on how well they do if they do happen to become infected with COVID-19?
And the reason that's so interesting is because there has been a controversy around ARBs, angiotensin receptor blockers like valsartan and losartan, as well as ACE inhibitors like lisinopril.
Yeah. Well, again, this is another great example where, based upon pretty flimsy evidence, people jump to a lot of conclusions. And, every professional society in my field in cardiology has put out a warning to people saying, don't stop your blood pressure medications because you read, somewhere on the internet that maybe these drugs make it easier for you to get infected with this coronavirus. And there have now been several studies done that indicate that there is no apparent relationship, beneficial or harmful, between these medications, the angiotensin receptor blockers and the ACE inhibitors, and COVID-19 infection. I must tell you that I've been very disappointed at the way this flurry of poor quality evidence seems to disseminate around the world, and people are jumping to conclusions based upon not very good studies. And everybody needs to take a deep breath and go through the kind of rigorous scientific methods that we use to determine whether something is effective or ineffective. And in this case, I worry that people have been harmed by stopping their blood pressure medications, having their blood pressures go through the roof, and having a stroke or a heart attack as a consequence of prematurely stopping medications they should be taking.
Well, and of course, it's a very stressful time, and we know that stress can affect the cardiovascular system, blood pressure, and heart. How is it affecting your patients?
Absolutely. Look, our patients they're very stressed, and we're trying to handle both the physical and the psychological aspects of this disorder. There's a lot more depression out there. There's a lot more anxiety, neither of which are good for the heart. There's a lot of data to suggest that depression is associated with worse cardiovascular outcomes. We feel very badly for our patients. And what I've tried to do, and many of us are doing, is having what we call virtual visits, where we actually interact with our patients, over the web or via telephone, and try to give them a medical appointment. It's not as good as seeing them in person, but at least they feel safe and they feel like they're being appropriately cared for. And we can make adjustments to their medications and listen to their problems and try to address them. We'll be happy when the epidemic subsides and we can go back to seeing people in person again. We're just now opening up at the Cleveland Clinic to outpatient visits, and I've got several actually on for tomorrow for the first time, and I'm looking forward to seeing my patients again, face to face, or should I say, a mask to mask, because we're going to all be masked when we see each other.
Oh, that sounds very sensible. Is it too early to tell what the long-term effects of COVID-19 might be on a person's health?
I do think it's too early. Most infections like influenza and, other viral infections, if you recover from it, you get the antibodies, you're permanently immune, you don't seem to have any long-term health consequences. But there have been exceptions. There is some evidence that the 1917, 1918 flu epidemic, that there was an increase many years later in Parkinson's disease. Some people think that might have been a trigger for some of those cases in the previous generation of Parkinson's disease, a neurological disorder that is, quite serious. So late complications remain to be seen. We'll have to watch very carefully for them. But most of the people that I am aware of who have gotten through the infection and recovered appear to be normal, at least in the short run. But obviously there are things we don't know.
Dr. Nissen, is this pandemic having an impact on cardiovascular research?
It has had a really serious impact. One of the things that I do is large scale, often global cardiovascular outcome trials. I'm actually responsible as the study chair now for 8 trials, 4 of which would be classified as mega trials that involve something like 10,000 patients or more each. And in each case, we have had to curtail activities. That means in-person visits by patients. In some cases, we're having trouble delivering study drug to patients. We've actually put some of our trials on hold so that we actually can't enroll new patients in the trial. These are, some of them are for therapies that I've waited 30 or 40 years to develop. We're conducting a very large trial for an extremely interesting and previously untreatable lipid disorder known as lipoprotein(a), and we can't really enroll the trial until we get this epidemic under control. It breaks my heart because I really want to bring those patients a therapy that will help to protect them against heart disease, and we can't move forward with it until the epidemic subsides.
Well, we've been very interested in Lp(a) for a long time, dating back to the early days of the statin treatments, and we too are disappointed that trial is now on hold. Dr. Nissen, you have been involved, if I'm not mistaken, in overseeing a little bit of the remdesivir research, and I understand that you were disappointed that a very large government-sponsored trial was cut short. Why was that?
Well, I wasn't responsible for overseeing it, but, I often get asked by the media to comment on these things because, what I do is I do clinical trials, and so I kind of understand how to do it. So here was the concern that I expressed. The study was stopped prematurely because it showed a modest shortening of the duration of illness for patients that were given the drug remdesivir. But at the time it was stopped, it was just short of having enough statistical evidence to determine whether remdesivir could reduce mortality. Reducing death due to the coronavirus is the most important outcome. And I was frankly puzzled by why the Data Safety and Monitoring Board would stop a trial prematurely on the verge of having enough statistical evidence to answer the question about whether the drug could have an effect on mortality, when just going on for a few more weeks potentially could have answered that pivotal question. And so, I don't find the explanations for the decision convincing. And I've commented very publicly that I was disappointed that it was not done in a way that would answer that question. Here's the problem we face now. If you're a patient and now the FDA has provided emergency access to the drug, and somebody says to you, I want you to go into a trial where half the patients are going to get placebo and half the patients are going to get remdesivir, would you enroll in such a trial when you can just get remdesivir? And so I'm worried we may never get the answer to whether or not remdesivir can actually reduce death due to coronavirus. And we need that answer.
Well, a lot of people have been counting on it because, let's be honest, there really is nothing else at the moment. And, the early results were modest. They did seem to have some benefit. Dr. Fauci, who we have great regard for, was positive. But I'm hoping that we'll have better data, that the clinical trials haven't now completely ceased. And so your thoughts about this drug and other drugs on the horizon, because I know an awful lot of our listeners are praying for some kind of treatment that will protect them, or at the very least shorten the duration of the illness and reduce their risk of death.
Well, like the two of you, I do have great respect for Dr. Fauci, but of course the decision making in the clinical trial belongs to other people, although he's in charge of the institute. I am concerned that we might not get the answer, that there are some ongoing trials. I don't know how far along they are. I don't have the details, but I do know that once a drug has been approved by the FDA and is now available to patients, conducting the kind of randomized placebo-controlled trials where half the patients get a placebo and half of them get the real drug becomes very difficult. So I don't know if we're going to get a definitive answer, certainly not in the near term. This was one of our best hopes, short of a vaccine, that we would have this drug, which is on the shelf. It can be manufactured. And if it is very effective at preventing mortality, then it is of great importance to patients. And so I want that answer. And I had been involved in the trial, I would have been willing to wait a few weeks to get that answer rather than rush with a press release the minute that this interim analysis, that's a partway done trial, when it showed a somewhat shortened illness, I would have said, let's wait, let's complete the rest of the study and get a more robust answer to the big question, which is mortality.
Dr. Nissen, what do you say to people who go, well, wait a minute, it's well and fine to have double-blind, placebo-controlled trials when things are normal, when you're testing a cholesterol-lowering drug, for example. But these times aren't normal. We have to take exceptional steps, maybe even shortcuts, to get to something that might work. There are a lot of people who are sort of, I won't say rejecting randomized controlled trials, but they're in a hurry. Why, from your perspective, is it important to have those randomized controlled trials even now in the middle of the pandemic?
History has been very unkind to shortcuts in medicine. We've made just, catastrophic mistakes when we've looked at what we call observational data, which is not randomized data. I could give you a dozen examples. The best one I can think of was when all the observational studies said that women should take estrogen after menopause because it would prevent heart disease. And in fact, we were told it was unethical to do a randomized controlled trial because it was obvious that estrogen reduced the risk of cardiovascular disease. And we did the final randomized controlled trial. It went exactly the opposite way. And so you just can't take shortcuts with science and get the right answer. And this is far too important to do sloppy research. In fact, I would argue that in an emergency situation like this, it is even more important to do it correctly so we get the right answer, because there are millions of people counting on us to get the right answer. And if we draw conclusions based upon incomplete data and get the wrong answer, it's harmful, and we don't want to do that.
You're listening to Dr. Steve Nissen, Chief Academic Officer of the Heart and Vascular Institute at the Cleveland Clinic.
After the break, we'll consider the value of stents for treating heart disease compared to medications or lifestyle changes.
How have cardiologists changed their views on stents over the years?
Exercise is crucial for heart health, but you can't go to the gym during lockdown. What does Dr. Nissen do?
We'll also ask him about a heart-healthy diet.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
This People's Pharmacy podcast is brought to you in part by Verisana.com.
Verisana Lab offers home health tests that allow you to monitor your hormones and health conditions. You can take control of the quantitative assessment of your health and learn about male and female hormone balance, the stress hormone cortisol, leaky gut, gluten intolerance, or your gut microbiome.
Take a more active role in tracking your health and take 20% off your first order of a mail-in testing opportunity with the discount code PEOPLE. That's uppercase PEOPLE. To learn more, go to Verisana.com. That's Verisana.com. Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Verisana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at Verisana.com.
And by Kaya Biotics, probiotic products made in Germany from certified organic ingredients. KAYA Biotics.com.
Today, our topic is keeping your heart healthy. One of the most common heart procedures has been angioplasty with the placement of a stent in a narrowed coronary artery. How well does that work?
We're talking with Dr. Steve Nissen. He's the Chief Academic Officer of the Heart and Vascular Institute at the Cleveland Clinic.
Dr. Nissen, we've just been talking about the importance of randomized controlled trials done well to answer our questions about how to treat serious problems. And late last year, a large international study showed that stents, which are a very common treatment in cardiology, are actually not better than lifestyle and medication improvements if people have a heart disease that is stable. Can you explain that to us, please?
Well, again, it's a really interesting result, and some people found the result not surprising. I'm one of those people. But let me see if I can put this into context. 13 years ago, a study was done. It was known as the COURAGE trial. It was a randomized controlled trial in which half of the people got early stenting for their stable coronary disease. And it's important to understand we are talking about stable coronary disease. Everybody agrees that getting a stent, if you're having a heart attack, is a life-saving intervention. We're talking about people that have stable, maybe they have some chest pain, other symptoms. We learned in the COURAGE trial, done now 13 years ago, that there was no difference in the rate of death or heart attack in people that got a conservative approach, which is basically just medicines alone, versus those that got a stent and the same medicines. So there wasn't any incremental benefit of having your coronary stented. There was a lot of criticism of that trial. The interventional cardiology community didn't particularly like the result, but it is what it is. So the new trial, known as ischemia, went a step further. They required you not only to have stable coronary disease with generally chest pain, but you had to have a study, an imaging study, that showed a decrement, a deficiency in blood flow in one or more of your coronary arteries. That's what ischemia is. Ischemia is a deficit in blood flow to part of the heart muscle. And
so this would be what we call a blocked artery.
Yes, but not. Now, the arteries weren't directly imaged prior to randomization. It was an indirect measure using various techniques such as a nuclear scan or other evidence for the presence of, or at least inferring the presence of, a blocked artery. And so those people then had to have ischemia, and then they were randomized either to an invasive strategy where they had heart catheterization, generally followed by stenting, or a conservative strategy, which involved medications alone. And they were followed for a long time. Now, the study was sponsored by the National Institute of Health, actually the National Heart, Lung, and Blood Institute, and was done, by very capable investigators that included, by the way, interventional cardiologists. Many of them were involved in the leadership. And when the study was done, there was no difference between the two groups in either heart attack or death or the need for another procedure to be done. In other words, the results were the same. And so it reaffirmed the findings from the COURAGE trial, but perhaps in a little bit sicker population that had more evidence for a deficiency in blood flow. Now, I know it's counterintuitive for a lot of people. Think about this for a moment. You've got a blockage in your coronary, and fixing the blockage with a stent would intuitively, you would think, would actually result in a better outcome than leaving the blockage alone and not fixing the blockage. But it turned out not to be the case. Now, we think we understand why, but the bottom line is patients now, again, we can say to patients, you have choices. If you have tolerable symptoms, most people in this study did, and you're otherwise doing well, you can certainly undergo a trial of medical treatment. If you do well and you have no further difficulties, there's no need to rush ahead and have an angiogram and a stent placed in your coronary arteries, because it does not produce an incremental benefit, over the next, say, at least, 5 years or more. And that's a very important finding.
Dr. Nissen, if we were to dial back about, maybe 15 years, and a patient went to see his or her cardiologist and said, doctor, I'm having a little chest pain. When I walk up a hill or up steep steps, I get a little short of breath and I feel a little chest pain. Or if I'm under a lot of emotional stress, sometimes I can feel that pain in my chest. And the doctor says, okay, well, George, let's get an angiogram, take a look. And they take a look and they say, you've got 30% blockage in one of those coronary arteries. You're a heart attack waiting to happen. This has been referred to as what is it, Terry? The oculostenotic reflex?
Yeah.
So maybe you can explain what the oculostenotic reflex is and why that message is no longer appropriate.
Well, first of all, I think even historically, people would not stent a 30% blockage. In general, you don't have problems with the ability of the coronary to flow blood to the heart muscle until you get to about 70% or so blockage. But there were a lot of people back then that had some chest pain. They had a 70% blockage on an angiogram, and people would just proceed right away and put a stent in. And part of it is this idea that it seems so intuitive that if you have a blockage and you fix the blockage, it must be a good thing. And it's another reason why we need randomized controlled trials, because as intuitive as it may seem, it turns out not to be true. So the oculostenotic reflex is kind of a tongue-in-cheek comment that the oculo is the eye and the stenosis is a narrowing in the coronary. So the eye sees a narrowing and the reflex is to put in a stent. So some people called that an oculostenotic reflex. And it's a bit sarcastic and, probably not the best term in the world. But that is something everybody has heard. And we don't need to have a knee-jerk response and fix every blockage in the coronary artery in people who are stable. And we don't even need to do an angiogram in many of those people because they're going to do very well with medical therapy.
Dr. Nissen, I wonder if you could sketch out for us not so much all the details of medical therapy, but what can people do for themselves to keep their hearts healthy if they have learned they do have heart disease?
Well, the key and something I've now spent the better part of my career advocating is treating the risk factors. If you have a high LDL cholesterol, that's the bad cholesterol. We have amazing drugs to lower LDL cholesterol, of course, including the statins, which are amongst the most commonly used drugs in all of medicine. Another drug called ezetimibe, which blocks the absorption of cholesterol. We have some powerful new drugs that can be taken by injection called PCSK9 inhibitors. And we have a new addition recently, within the last month or two, a drug known as bempedoic acid, which, maybe another time we can talk about. And so lowering cholesterol, LDL, lowering the bad cholesterol has been proven to be, over and over again effective. So is lowering blood pressure. We have very good blood pressure lowering medications. If you have high blood pressure, get it treated. You can reduce your risk of a heart attack or a stroke. Smoking is a risk factor. Nobody in this day and age ought to smoke cigarettes. Smoking cigarettes is like playing Russian roulette and putting 5 bullets in the gun. It's just asking for trouble, not just lung cancer, but coronary heart disease. We have the issue of diabetes, and diabetes now can be treated. We have amazing new medications for diabetes that have been now shown to reduce the risk of heart attack and stroke. And so that can be done. And part of the reason why medical therapy is doing so well in studies like ischemia is our drugs are so much better than they were. There is, however, one risk factor that we cannot control. You can't pick your parents. And so genetics, inheriting a family history of coronary heart disease, we can't fix that. But virtually everything else, we have very good treatments for, and everybody ought to avail themselves of those treatments. One more thing, keeping your body weight down, having a normal body weight, not being obese. And the best medicine of all is not even a drug. It's exercise. There's an incredible effect of exercise on the risk for coronary heart disease, stroke, and many other disorders. Getting 10,000 steps a day or more, I kind of average about 17 or 18,000 steps a day. And frankly, it's one of the most important things I can do for my own health. And it's something everybody can do, or most people can, if you don't have an orthopedic problem, is get out and walk, and it will keep you healthy. We're not as sure about the effects of diet. And there's a lot more controversy about what's the heart healthy diet. And that's a long discussion, maybe for another day. But certainly, limiting meat intake is probably a good idea. Having more fruits and vegetables. What we like to advocate is the Mediterranean diet: olive oil, fruits, vegetables, lots of other good things, not too much meat, maybe a little more fish than meat. All of these things are people that everybody can do for themselves. And if you do that, your chances of getting coronary heart disease are dramatically reduced.
Of course, at this time, people may feel that they're having a harder time getting their exercise, but you're saying just walking, if you can get out at all, wear your mask and go outside, stay away from other people, and see how many steps you can get.
Absolutely. And, these days, an indoor exercise cycle, pretty inexpensive. Some people have treadmills at home. It's a little more expensive to have that. And these other fancier devices are now widely marketed. But find a way to do some form of exercise. I think it's perfectly safe to get out with your mask and stay 6 feet away from everybody else and go out and walk. And, no matter what time I get home at night, I try to go out and take a walk after dinner. Even when it's dark in the winter here in Cleveland, I put on a headlamp and the right kind of reflective clothing, and I go out and do it. And I make it a matter of my daily routine.
You and Dr. Anthony Fauci.
Dr. Fauci's an amazing guy. He's 79 years old. He looks fantastic. And I figured he probably takes good care of himself. And, it's good to see that. And, I'm not his age. I'm 71 years old, but I'll be working 10 years from now.
Everybody likes to know what health professionals are doing for themselves when it comes to diet. And you've already pointed out that there's a lot of controversy. It used to be that margarine was supposed to be better than butter. And now, of course, that's been completely reversed. But I think our listeners would like to know very quickly, what is the Dr. Steve Nissen preferred dietary approach? What are you eating these days, especially now that we've all been kind of holed up in our homes for so long? What are you eating?
Well, I follow the Mediterranean diet. Fruits, vegetables, whole grains. Olive oil is the primary oil that we use in our cooking. We occasionally use canola oil. We hardly ever have meat. I don't think we probably have meat even once a month. We might have a little bit of chicken from time to time, but not that very often. So it's really not quite a vegetarian diet, but it's certainly low in meat, low in saturated fats, using healthy oils and whole grains. Common, for us to have a dinner that's based upon a whole grain dish, quinoa, that sort of thing. There are lots of choices. If you want to go out and Google or use your search engine and look up Mediterranean diet, you'll find some great tasty recipes. And as far as we can tell, the best evidence suggests that's the most heart-healthy diet.
And what about fish and fish oil in particular? There's been some new data suggesting fish oil might be beneficial.
Stay tuned on that. I'm going to be reporting on a 13,000 patient trial that we've closed out just within the last few weeks. There is a study, a fish oil study, that did show some benefits for a prescription fish oil. There is some controversy about the study. I personally have some doubts about it, but we're going to be weighing in on this in the year 2020, and stay tuned and we'll tell you what we think.
Well, we will look forward to hearing about that. Dr. Steve Nissen, thank you so much for talking with us on the People's Pharmacy today.
It's always a great pleasure to talk with you, and your questions are terrific, and I hope your audience appreciates your show.
You've been listening to Dr. Steve Nissen. He's Chief Academic Officer of the Seidel and Arnold Miller Family Heart, Vascular, and Thoracic Institute at the Cleveland Clinic. He holds the Lewis and Patricia Dickey Chair in Cardiovascular Medicine there. Dr. Nissen has conducted countless clinical trials and has served on the FDA Cardiorenal Advisory Panel. His book, co-authored with Dr. Mark Gilinoff, is Heart 411, the only guide to heart health you'll ever need.
Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC. This week, the show was recorded from our home studio.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is brought to you in part by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
And by CocoVia, offering plant-based nutrients in the form of cocoflavanols for brain and heart health. Online at cocovia.com.
Also by Kaya Biotics, probiotic products made in Germany from certified organic ingredients. KAYA Biotics.com.
To buy a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1213. The number again, 800-732-2334, or on the website peoplespharmacy.com.
When you visit the site, you can share your thoughts about today's show. Do you have a stent? How well is it working for you?
At peoplespharmacy.com, you can subscribe to the podcast. When you visit the website, you can also sign up for our free online newsletter to get the latest news about COVID-19 and other important health stories. Choose the frequency you prefer, daily, twice a week, or weekly. In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thanks for listening. Please join us again next week. Thank you for listening to the People's Pharmacy Podcast. It's an honor and a pleasure to bring you our award-winning program week in and week out. But producing and distributing this show as a free podcast takes time and costs money.
If you like what we do and you'd like to help us continue to produce high-quality, independent healthcare journalism, please consider chipping in.
All you have to do is go to peoplespharmacy.com/donate.
Whether it's just one time or a monthly donation, you can be part of the team that makes this show possible. Thank you for your continued loyalty and support. We couldn't make our show without you.